talks about the initial PAH treatments and how we decide what to treat people with. So what are the goals of treatment? There's a bunch of them that we as physicians have and that we hope that you share with us. One of them is that we hope that your hemodynamics get better. And by hemodynamics, I mean the numbers that we measure in the time that we do the right heart catheterization. So we're hoping to make those numbers better. And why do we care about that? Well, we know that those numbers translate into how you're feeling, how much you can do, and how long you're going to live. So it sounds like these numbers are overly important to us, but it's because we know what those numbers are standing in for, which are things that are sort of measured by your long-term survival and how you're doing. Other goals that we have are, improved exercise capacity. And by exercise capacity, I mean ability to do your activities of daily living in particular. So our hope is that we can take people who are telling me that they can either not shower or bathe themselves because they're so out of breath to being able to cook dinner, go to the grocery store, walk around, go to church, do whatever activities are meaningful for those folks. And for some people who their symptoms aren't so severe, it may be that they're short of breath when they walk around the block, but they can no longer play sports. Our hope is that we can get them to the point where they can play sports. So for each person, that improved exercise capacity depends, one, on what kinds of things they would like to do, and two, how sick they were when they first came to see us. And along with that is function, so basically how well you can function in your life. We also want to keep people from getting worse, so sometimes our treatments don't really make people much better, but they do keep them from getting worse. That's not really my favorite goal, but it does happen sometimes, and we have to accept that that's the case. And the other hope is that we will keep people living longer, and I think that that's one of your all's goals. So one of the big movements in the pulmonary hypertension community is to listen to patients and listen to what people want for themselves. And most people, when I ask them what they want for themselves, tell me they want to be able to do more and they want to be able to live as long as possible. And I think those are reasonable goals that we all share. So when Dr. Pugh and Dr. Robbins and I focus on 6-minute walk distance, like how far you walked in 6 minutes, or the right heart catheterization numbers, we're doing that because it's basically a marker for how well you're able to function in your life and how long you're going to live. Because we don't have crystal balls, so that's what we use those things for. So sometimes when you read papers about pulmonary arterial hypertension, and I'm really going to focus on pulmonary arterial hypertension for this part. You might see people talk about background therapy, and this is therapy that many, if not all, patients are taking. And that includes medications like diuretics, which the most commonly ones, so these are medicines that make you pee a whole lot. And the most common ones of those are furosemide is the generic name, or Lasix. And spironolactone, or the brand name for that one, is aldactone. And these are sort of partner diuretics and make people pee. Another common medicine that people are on is a blood thinner called warfarin, or the brand name of Coumadin. And that thins out their blood and prevents cells from basically forming clots in the pulmonary arteries when blood flow is slow. Some people in the heart catheterization lab have normalization. They completely normalize their pressures when they inhale a medicine called nitric oxide. And it's very rare that this happens, but it does happen. And those people can be treated with a medicine for blood pressure and the high blood pressure in the body called calcium channel blockers. But we don't use calcium channel blockers if patients don't respond to that medicine in the cath lab. And like I said, it's rare, so most patients are not on that medication. And then some people are on medicine called digoxin or lanoxin that helps their heart squeeze. It's not one that Dr. Robbins, Pugh, or I use very commonly, but sometimes people do use it. So pulmonary arterial hypertension, it says here, is a complex disease that results in this buildup of vascular tissue in the arteries of the lungs. So if you remember that picture of the pathology, it looks like an onion skin, like the whole blood vessel is thickened and has this buildup of tissue. We don't have a cure. I promise we are working very hard to find a cure, and that's really one of my lifetime goals in my career. And I think we all hold out hope for that, but we don't presently. But we do know that certain pathways and certain molecules are very important in the development of pulmonary arterial hypertension. And we have medicines that can target these pathways. And we know that treatment with these medicines can really make a huge difference in people's quality of life, how much they can do, and how long they can live. And so those molecules that are important are endothelin. And we know that concentrations of endothelin are increased in the lungs and the blood of patients who have PAH. Nitric oxide is a blood vessel relaxer, and the concentrations of nitric oxide are reduced in the blood and the lungs. And prostacyclin is another molecule whose levels are reduced in the lung and the blood. And the end result of these changes is that pathologic narrowing of the blood vessels that we saw before. And our current medications basically target these pathways. So here are the FDA-approved therapies for pulmonary arterial hypertension. The first one that ever became FDA-approved was epoprostenol, and this is marketed under the brand name Flolan and Velletri. Those are the two that we have. First we had Flolan, and then Velletri came out a few years ago. It was really a game changer in the field of pulmonary arterial hypertension because before the FDA approved it in the late 1990s, the only medication that we had was that background therapy that I mentioned before. And this medication, epoprostenol, has really been life-saving for a lot of people. There are other forms of it. There's an inhaled form called iloprost that you can take 6 to 9 times a day. And then there's treprostinil, these are all sort of cousins of the same medication. Treprostinil is given by a subcutaneous infusion, or it can give an IV. And it also has an inhaled form too, and it's not on this slide, but it has FDA approval as an oral form. Every pulmonary hypertension physician that you see will have a slightly different opinion about which medication is the best for an individual patient or really sick patients who have pulmonary arterial hypertension. But at Vanderbilt, we very commonly, in patients who have a lot of symptoms and have concerning findings on their heart catheterization, we most commonly recommend this medication, epoprostenol, because we have the most experience that it's the most potent medication available for the treatment of pulmonary arterial hypertension. The second class of medications that was FDA approved was the endothelin receptor antagonist. So between the late 1990s and 2002, all we had was IV medication for pulmonary arterial hypertension. But endothelin receptor antagonists were FDA approved in 2002 when we had a pill for the first time to treat pulmonary arterial hypertension. And there's 3 FDA-approved endothelin receptor antagonists. First is bosantan, which is an oral pill twice a day. And that was the one that was first approved in 2002. But that ambrisantan came out. It's an oral pill once per day. And then most recently, since this slide was made, macitentan came out, and that is an oral pill also. So bosantan, the brand name is Tracleer. Ambrisantan is Letairis, and macitentan is marketed under the name Opsumit. So you may have heard those names. And then the last class of medications that received FDA approval were the phosphodiesterase type 5 inhibitors. So I will tell you a funny story about how these drugs were approved. Initially, Pfizer had this medication called sildenafil, and they thought it was going to be a medicine to treat high blood pressure in the body. And so they did a trial with like thousands of people, and at the end of the trial, it turned out it actually didn't work all that great for high blood pressure in the body. So Pfizer called up all the people who were in the trial and said, we're shutting down this trial, it didn't work, bring your pills back. And it turns out most of the men who were involved in this trial did not want to bring their pills back, and they couldn't figure out why. And so they started asking, and now it's marketed under the brand name Viagra. So I hope all the grown-ups in the room kind of get where that's going. So it turns out, too, that then they started doing research in this pathway, and it looked like there was a lot of phosphodiesterase in the lungs. So there's basically two places that it exists. The reason that it's marketed as Viagra and the lungs. So they then looked into the treatment of pulmonary arterial hypertension using sildenafil and did a big trial, and it turns out, lo and behold, it works to treat pulmonary arterial hypertension as well. So there's a funny story. Turns out, not a good blood pressure medicine. It has other uses. But it also can be used to treat pulmonary arterial hypertension. So sildenafil is called Revatio when it's treating pulmonary arterial hypertension, not Viagra, but it's the same drug. Tadalafil then also got FDA approval, and that is Cialis. That's the one that you see in the commercial with the bathtubs, but it's called Adcirca when we're treating pulmonary arterial hypertension. And then the last one that recently got FDA approval that's in this pathway, but slightly different, is a medication called riociguat or Adempas. And that one actually is not used to treat anything else, just forms of pulmonary hypertension. So how do we decide who to start on which drug? Well, every patient is different. And now we have a lot of options. In the past, we really only had like 2 or 3 drugs, but now we have a lot. And it makes more decisions for patients and doctors to make and think about when we recommend treatment. One of the main questions that we used to ask is, should we use endothelin receptor antagonists or should we use PDE5 inhibitors in people who can be treated with oral medication? It turns out there was a recent trial that was finished, and it looks like treating with both drugs together is better than one alone. So we don't really plan on having that either or conversation anymore. And it's also unclear, too, when patients should participate in clinical studies and how to enroll people in clinical trials and what trials to enroll them in. So those are a lot of the decisions that we make every day. Just to mention a little bit more about the experimental drugs, as I said before, we don't have a cure. And so since our hope is to develop a cure, we ultimately will need to find new drugs and have patients participate in these drug trials. But that is a big commitment for patients. It is it's a very different form of treatment, or it can be a different form of treatment than what we're used to. So it's not an easy decision to decide to do that. So what are the factors that we use in recommending an initial therapy for pulmonary hypertension? Well, it's always a recommendation that's based on assessing how severe the patient's disease is and how willing the patient is to take different medications. So our recommendation usually is based on the severity of the condition. So we would like to avoid specifically death, but also hospitalization and transplantation and worsening. So we look at the heart catheterization data. So we look at how much the heart is under stress and how high the pressures are. And we also look at the echocardiogram that tells us how well the right side of the heart is squeezing. And we tend to look at some blood markers that tell us if the heart is under stress. And we use those together to decide how severe the condition is. So the more severe the pulmonary arterial hypertension, the more aggressive the treatment should be. Therefore, one size doesn't fit all. And a lot of times, if you talk in a group, somebody will say, well, my doctor said I could be treated with pills, and somebody says, well, my doctor said I could be treated with this inhaled medicine, and somebody said I needed all these different pills, and somebody said I needed a pump. Well, those different recommendations are coming from different diseases, and everybody is different, so we have to individualize our therapy. But the other things that also come into play are patient preferences. Like some people just say, I will or will not do some therapies. Some things are what seems fine to one patient does not seem fine to another patient, and so we need to take that into consideration. And other medical conditions, social support, patients' reliability, their willingness to come back and see us, and the cost of medications all play a role. So the things that we talk about, I mentioned the hemodynamics from the heart cath, but also the 6-minute walk distance, the functional classification, which is a sense of how well you're able to do your activities of daily living, the echo, blood markers, All of these things together help us figure out how severe the condition is. So let's talk for a second about how we give the prostaglandin medications. So these medicines are extremely potent, but in the past have not been able to give orally. And although the FDA has approved oral treprostinil, we haven't used much of it at Vanderbilt. Most prostaglandins are given by one of these devices. So this is the one that probably is most familiar is the CAD Legacy pump. That's how we give IV epoprostenol, either Veletri or Flolan. But there's also these other mini-med pumps that can be used for the subcutaneous treprostinil infusion. And then there's inhaled for iloprost or treprostinil, and they're sort of like fancy nebulizers that give the medication that you can inhale that way. So the medication is sort of separate from these things, but these are the delivery devices. We don't have a slide about pills. I think everybody knows what a pill looks like. So what day-to-day living with pulmonary arterial hypertension? Well, it's different for everybody. Everybody's symptoms are different. And some people tell me that their main problem is that they're tired. Some people say they feel absolutely fine unless they try to get up and do anything, and they can't get up and do anything. Some people, their big issue is that they can't get to their mailbox because their mailbox is up a hill. Everybody has a different experience with this. Moreover, it can be different from day to day. I've really been impressed with how people sort of gather up all their energy and do something like cook a huge dinner for their family, and then they're just worn out and exhausted for the next week after. So there's somehow there's day-to-day variability in how people's symptoms are. It says you are the expert on you and how you feel, and I think that's really important. You people who have this disease really are experts in how their feelings are, and it's a very personal experience. So stay in touch with your healthcare people. I think that one of the things that I try to do when people come to see me in clinic is say, how are you feeling? What is your life like? What are you up to? And listen to patients. And if you feel like something is wrong, please feel free to call your doctor, call us, call whoever is treating your pulmonary hypertension and say, I am not right, and be your own advocate, because you really do know better than anybody else what you're feeling. So who treats pulmonary hypertension patients? Well, first, I guess, in the center of this is the pulmonary hypertension patient. On the day-to-day front lines, the pulmonary hypertension patient is the person who experiences these conditions. But they work with other people who are around this circle to help make their lives better and help them live longer. And people that are often involved in the care are, I'm a pulmonologist, and Dr. Robbins and Dr. Pugh are pulmonologists, and Dr. Austin too. But sometimes cardiologists treat pulmonary arterial hypertension. It just sort of depends a little bit on how the center works. But we do work closely with our cardiologists too at Vanderbilt, who do the heart catheterizations and the echocardiograms. And sometimes people have trouble with arrhythmias, heart rhythm problems. And so we work every day with the cardiologist. Rheumatologists can be involved, particularly in patients who have scleroderma or connective tissue disease. Primary care doctors are really critical. As we take care of patients all over the Southeast, many patients can't come in every time they have a problem and see us because the distance is just too far to drive. So a lot of primary care doctors are involved with measuring blood values, seeing patients when acute problems come up, etc. I can't say enough about the nurse or nurse practitioner in this. For those of you who are followed at Vanderbilt, you know that Kimberly and Amy are they are the workhorses of our clinic. They make sure that all the medication gets ordered, the prior authorizations go through, they coordinate care with the specialty pharmacies, they do education for patients, and I think most of all they do like a tremendous job of hand-holding and explaining and listening. So the nurses and nurse practitioners are really critical. Respiratory therapists can help with a number of things like those nebulizer devices that I talked about. Health educators, physician assistants are also involved, just depending on how the practice works. So there's a lot of people involved in this care. So what should everybody know? it's good to live a healthy lifestyle if you have pulmonary arterial hypertension, and even if you don't. So maintain a balanced diet, keep your body weight healthy. The smaller your body is, the less blood your heart has to pump. And so keeping your weight low is, not exceedingly low, but in a healthy range is critical. It is okay to exercise. I get this question a lot, like, I get out of breath when I exercise. Is it bad for me? Am I hurting myself? Well, talk to your doctor because, like I said, everybody's different. But for the most part, walking to the point where you're mildly out of breath is not hurting anybody. But you don't want to exercise to the point where you're seeing stars or passing out. So we usually do advocate patients doing modest exercise. Reduce salt intake because the more salt you eat, the more fluid your body holds on to, and the more diuretics you're going to need, and the more short of breath you can get. Make sure you get enough sleep, and manage your anxiety, stress, and or depression. This is a lovely recommendation to make, but it's a lot easier said than done. But just be aware of your own response to stress and anxiety. It's going to come up in everybody's life, undoubtedly, but we can address how we face those issues. And then working with your healthcare team is really critical. So take your medications as they're prescribed. If you're not taking them, then communicate that and communicate the reasons why. It may be side effects. For instance, some of the medications that we prescribe make people have nausea or vomiting. And if those are side effects that you're having that make you not want to take your medicine, then let us know so we can try to address that. Keep a journal about your side effects and talk to us, your well-being. Don't take vitamins or supplements or over-the-counter things without informing physicians. This is an important thing to know because some of those have stimulants that we think may be making your pulmonary hypertension worse, or may interact with your medications. Always tell your healthcare providers if you're having any kind of surgery because we like to have it done oftentimes at Vanderbilt or where you can be followed or be in touch with your doctors to make recommendations. So that's a really critical thing. And let us know about immunizations and then follow up on the plan, but don't be afraid ever to ask questions. What to avoid? For people who are still able to have children, who are women, we recommend that they no longer have any more children, so we recommend that they avoid pregnancy because their heart and lungs really can't handle the stress of pregnancy. Avoid constipation, which interestingly, I don't know that I have any patients that seem to have this problem because almost all the medicine causes diarrhea. Avoid excessive humidity and hot weather, and there should be like a little asterisk here, unless you live in Tennessee, which is, I don't know how you could. High altitude can make breathing worse, dehydration, excessive physical activity. That's what I mean by the, exercise to the point where you're seeing stars or going to pass out. Oral contraceptives may have some hormones in them that may worsen pulmonary hypertension, so before taking those, definitely talk to your doctor. Diet pills is a big one. A lot of medical weight loss centers will prescribe diet pills, and we try to stay away from the diet pills because some of them have been associated with pulmonary hypertension. Don't use alcohol excessively or take drugs. Over-the-counter decongestants are another one. They can worsen pulmonary hypertension potentially. And then avoid smoking. Obviously, this is a lung disease. You don't want to be around smoke or smoke yourself. So who are the support systems for PAH? Your friends and your family. They're your day-to-day support. The PHA has support groups, and I know Yvette could talk to you about that. But they also have great online information. And we can point you to some online support also through some other websites. They're more sort of knowledge-based. Doctors, nurses, physician assistants, nurses and case managers are day-to-day very important. Patient support programs, specialty pharmacy support programs have been really great for our patients, I think, in terms of getting medications, teaching, and working for prior authorization, et cetera. And then financial assistance programs as well. Okay, so in summary, work with your healthcare providers to find the right treatment for you. So to find a treatment that's acceptable to you, that will help you live longer and function better in your life. Never be afraid to ask for help when you need it. it is perfectly fine if you need help or if you're having a problem. Your healthcare team is here to help you. Follow through on your treatment plan and be a partner in it. So don't say you feel fine when you don't. Don't say you're taking your medications when every time you take them you feel like you're going to throw up. We just need to know this information and we can work with it. You are your own best advocate and an expert in your disease. And ultimately, knowledge is power. So congratulations for coming today, because I think you're doing the most important thing, which is learning about this disease and trying to help yourself.
One of the doctors decided that if they shocked his heart to get it back in rhythm, that because he had kidney failure, that would, and it did. It for a short time, his kidneys began working again, and he was feeling better. But it wasn't long till, he was gone, and there was things. So is that kind of part of what you have seen?
Yeah, so kidney failure is very common in end-stage pulmonary arterial hypertension, and then heart rhythm problems are also really common, and sometimes that's why people have to have their heart shocked either emergently or not so emergently, but it is common. It's, we see it.
The PAH things, they have a chrono 5 and it's small. Is that something that Velitri can be used with, or have you ever heard of it?
I have heard a little bit about these pumps, and you know me well enough to know that I'm like more of a broad brushstroke person, but I'm getting the shaking head over there, so it sounds like no, that probably doesn't work out. I have seen that too. The delivery device, I know for treprostinil gives you more options than for Velitri, and we just in general think that Velitri is a sort of, it's our preference essentially.
Remodulin has a pump that can be put internally. Is that not ever going to be an option for like Velitri?
It is. So the Remodulin pump that's subcutaneous, I don't think is FDA approved yet. There's still ongoing a trial, but it probably will never happen for Velitri because it has to be refilled so often, whereas the Remodulin can be refilled much less frequently. The drug is just stabler for a longer period of time. That might be a nice option, and we might actually reconsider our preference for epoprostenol if that pump comes out, because it's looks pretty convenient, but we'd have to see the trial data first.
I also wondered about, I don't know what it is because I've often wondered, but they're moving their own sites around with, I don't know what kind of.
It's Remodulin, I'm sure. So it's Remodulin is the brand name for treprostinil, and it's got a subcutaneous needle. So it looks like a beeper that they wear, and it's got this like wire that delivers a drug into a needle that's shaped kind of like this that goes into their skin. And every so often they have to move where that needle is so that they don't get an infection, or if it's bleeding or something, they have to move it around. I suspect that's probably what you've seen.
Do you see so many that happen like ours, where at the last minute we found out what happened and then he was gone?
We, unfortunately, still today, despite all the education that goes on, we still do have people who show up, very ill that we can't help. I can think of a handful of patients that's happened to since I've been at Vanderbilt, and it is one of the saddest things that I can say I've ever seen. Particularly when it happens to children, it's absolutely heartbreaking, and I can only imagine, what your experience was like. I think it's because the disease is so hard to diagnose and so uncommon that it's hard to figure out that that's what the problem is in some cases until it's really too late. But at the same time, we do have some people who we are able to diagnose with pulmonary arterial hypertension, and we're able to start therapy, and they can get better. So I've also seen patients who are started on medicine who get better, and I wish that had happened for your son. Mm-hmm. Yep, we definitely see that too. that it? You guys are too easy.